Okay, so in regards to getting blood products, we just need to make sure, remember I told y'all you never want to be the guy where somebody says, oh, why am I getting this? And you're like, I'm not sure. The doctor ordered it. If you're giving blood or you're monitoring blood, you want to know what your patient's red blood cell count is. You want to know what their H&H is. Never go give blood without knowing those baselines, without knowing your reason for administration. Same thing with potassium. If you're going in your room and you're hanging a potassium rider and your patient says, oh, what was my potassium? And you just kind of look at them and you don't know those things, they lose all confidence in you as a nurse, and you should not be hanging that potassium bag if you have no idea what their potassium is. So all of those things are going to go into play. And just make sure that you're aware of, potassium. If you're giving them magnesium, what is their mag level? If you're giving them, any electrolyte replacement, all of those normals that you learned in foundations, just ensure that you know those and what they are and what your expectation is for them to be after you administer those medications intravenously. And so we talked about this. Cultural beliefs and religious beliefs cannot be ignored. You need to know your patient's backgrounds, and you need to be aware of your family of actions, because sometimes people will go against their family wishes when it's their lives that are, on the line. So that's one of the questions that we would have to ask when I worked pre-op. We would get a blood consent signed prior to them going to sleep. Now, those blood consents are only good for 48 hours, 72 in some places. But basically, if you needed blood to save your life in an emergency event during this surgery, would you be willing to accept the blood? So you need to know, that's a big deal for many cultures. So you need that consent must be on the chart, and it must be a current consent. And so I had, when I used to ask that question, of several people say, well, my parents are Jehovah's Witnesses. And when I say parents, adult parents, this person was old enough to sign their own consent forms in their 20s. My parents are Jehovah's Witnesses, but if I'm dying, I want you to give me blood. That is not my beliefs. That's my parents' beliefs. So just ensure that you are getting the correct information and that you are being discreet. If your patient is not wanting that shared with their parents, that you're helping them, and to the best of your ability, maintain their privacy, because that is their personal decision. In much the same way, their parents may not, their parents may be for blood, and and I say parents, it could be a husband-spouse situation. It is the patient's personal choice whether they do or whether they do not want blood, and you just need to make sure that you respect it regardless of what it is, okay? So roles and responsibilities. These are your roles and responsibilities as a nurse. We've already said that they're limited by scope of practice, and they vary from state to state. So, and secondary to that, they're limited by the facility policy. So if for some reason your scope of practice changed, if the Louisiana State Board of Nursing said that LPNs cannot, under any circumstances, do anything that has to do with a central line, they cannot hang blood, and they cannot give IV push medications, but your facility policy said that you could, what trumps what? What do y'all think? Y'all understand my question? Who takes priority in that matter?
Would it be the facility?
Say that one more time.
The facility.
Okay, so the facility is actually secondary, and that's why I asked you guys that. So your scope of practice, your state board first determines what you can do. They're like they're the big dog. Think of them as, they're the big dog, and they say this is what you can do. And then beneath that is the facility in which you work and their protocols, and their policies. So if the state board says that you can, but your facility policy says that you can't, you still can't, because that facility is, where you're working. If the facility policy says, oh yeah, we let our LPNs do everything, but your state board said, but we don't, then your state board would trump them, okay? Now, I ask that your facilities should be, if they are run correctly and they are managed correctly, they should never have you try to do something that is outside of your scope of practice in regards to the Louisiana State Board of Practical Nurses. Thees that make sense to you guys? Because it's a trickle down. The state board says you can do this, and the facility policy bases their procedures and policies around that, is the way that it should truly work. But should your facility be out of line, you have your practice act, from your state board to back you up. But as it stands, because I don't want to confuse you guys, as it stands, if you have the knowledge, skills, and ability to do it, you can do it, okay, in regards to IV therapy. Roles and responsibilities continued are going to be safe initiation and monitoring. So remember when we were spiking our bags and we were setting our pumps and doing all of that stuff? We need to be really diligent when we're spiking that tubing to make sure that we're not breaking aseptic technique, okay? We need to monitor infection control. We need to make sure that we're scrubbing that hub when we connect our stuff for a minimum of 15 seconds. A lot of your stuff will say 30 seconds. 15 is the minimum, and then 30 is the preferred. So just make sure that you're at least at 15 seconds. It feels like a long time because everybody wants to just do one swoop. Just make sure you're really scrubbing and cleaning that hub. You must have informed consent. That's for blood administration. You don't need informed consent for just regular IV therapy of normal. That's covered when when your patients are first admitted and they sign all of their authorization to treat and stuff. It's covered in that. You must follow the legal standard of care. Can be voluntary or government mandated, and agency policy, which we've kind of talked about that. Negligence is when IV administration is not done in a reasonable and prudent way. And malpractice is when the basic standard of care is deviated. So as long as you are protecting your patient and you are inside of your scope of practice and you're ensuring that everything that you are learned is done, then you should never be put in a place where you've had malpractice or negligence. If you're doing those 5 rights, then you're in, mistakes do happen, but you shouldn't be hanging the wrong fluids, and you're having somebody check be in a second check for blood, you shouldn't be hanging it too fast. But at the end of the day, everybody is individually liable for the actions that they take. And one of the biggest things that I want y'all to understand about IV therapy, and I think y'all already do, if you accidentally give a patient the wrong medication PO, you have a little bit of time to respond before they have a major reaction or before, something bad takes place. If you give a patient a wrong medication IV, it's immediately in their bloodstream. It's already in their intravascular system. And so those effects are going to take place much, much, much faster. So you should always be equally careful, but if you're going to be extra, extra careful, you need to be extra, extra careful when you're given medications intravenously. Okay. Risk management and patient care with infusion therapy. So you want to their goal in risk management is to identify, analyze, and implement strategies to decrease liability and ensure a higher level of patient care. These are the committees at your jobs that are saying, okay, so we've had this many central line infections in the past 6 months. What is up? You know, are our nurses adequately educated on how to change these dressings? Are we changing them accordingly? Are they changing their IV lines, you know, every 72 hours as they're indicated, or every 24 hours if they're getting nutrition IV? So if you're given nutrition, parenteral nutrition, those lines are only good for 24 hours. If y'all want to make a note of that. You know, is our patient piddling with their IV? Is what is going on, you know, to cause these problems? Because the goal of risk management is to provide safe treatment and safeguard against further injury. So there's lots and lots of committees who continuously monitor this stuff. And at the end of the day, your patient's safety is of the utmost priority. So whenever your facility says, hey, we have to have a central line, you know, we have to have a central line dressing change in service and everybody has to attend, there's a reason behind all of that stuff. All right. So when we are, you know, fixing to start IV therapy, there are some important things that we must know prior to initiation. We need an accurate history. Do they have a history of CHF? Do they have any allergies that we need to be aware of? Have they had any recent changes in their physical condition, you know, in regards to weight gain, orientation, just anything? You just really need a good baseline with your patients prior to starting therapy. Check for discrepancies. So one of the things that we're watching when we're initiating IV therapy is their weight, right? And why do we care about their weight? Somebody tell me why.
To monitor fluid overload.
I hear you, see you talking, but I can't hear you. Tell me again.
To monitor like fluid overload.
Yeah, fluid overload. So if your patient one day weighs, let's see, if they weigh 180 pounds and then they weigh 185 pounds and then they weigh 174 pounds, and this is in 3 consecutive days, there's not a lot of consistency there, right? We want to make sure that if we're delegating that task to someone, are they zeroing out the bed fully? Are they weighing them at the same time every day? Making sure that we are basing our, you know, the information that we're gathering and the, you know, what we're basing our stuff on. So of course we're watching their INO and we're watching everything else as well, but we don't want to base everything on that one thing when there's potential discrepancies there. We want to look into those discrepancies a little bit. Urine testing, that would be one of the things we're looking for. You know, what is their specific gravity? What is, you know, their BUN and creatinine as far as blood studies go, their CBC, their BMP, all of these things to give us a baseline. Are they having behavioral changes? Are they, you know, what is going on with them at the start of therapy? Because if we don't document well at the start of therapy, then we're going to have a really hard time managing them throughout their therapy. And then in regards to documentation, so they have to, and we're going to talk more about, you know, what we're documenting specifically, but if they're getting IV therapy, then they have to have an IV, right? Either they have to have a peripheral IV or they have to have a central line. We need to document where it's located. We need to document what size it is. You know, is it a 22 gauge? Is it an 18 gauge? Is it in their left forearm or their right hand? Is there any redness around the site? Does it flush well? Is it patent? Is it hooked to fluids or is it just saline locked? All of those things need to be documented. So during an IV infusion, we have got to make sure that we're not letting, which you should be checking on your patients every 2 hours at minimum. But if we start a new infusion, we're not going to wait 3 hours before we lay eyes on our patient again. And their arm is puffed up the size of, I don't know, what's the little marshmallow guy on Ghostbusters? You know, we don't want their arm to look like that before we have stopped this infusion or we have, you know, even noticed that something's wrong. So early intervention is key regardless of what the complication is. So we have got to be monitoring our patient. We have got to be telling our patient, hey, if this starts burning significantly, give me a call and push that button. If your alarm starts monitoring, don't just push the silence button. Let me come troubleshoot it and see what's up, okay? So some complications that we are going to discuss and learn how to troubleshoot, and we've kind of already touched on some of this. Like I said, y'all might be a little bit bored during this because we've kind of talked about it as we've learned how to deal with these lines. But infiltration, phlebitis, ecchymosis, hematomas, circulatory system overload, equipment failure, kinks in the line, and displacement of the device from the vein. All of those things are things that could happen during an IV infusion, and we're going to learn our intervention for each. So, equipment failure. If our equipment, I mean, this is easy and obvious, but if our equipment is failing, what do we go do? Somebody tell me.
Change the equipment?
Yeah, change the equipment. Now, the reason I asked you that, I know that's an obvious answer. What do we do with the broken equipment, Brendan? Do we just
you have to document it?
Yes. Well, we'll document it and say, you know, that we've traded it out and tag it. Don't just put it back for another nurse to grab broken equipment. We need to tag it and go put it wherever the broken equipment goes, either in the bio. There's usually a bio room that they put that stuff in, and document that it's broken, so that we're not putting any other patients at risk by putting broken equipment back out into circulation. So little stuff like that. If there's kinks in the line, obviously we get the kinks out, right? If the IV is displaced from the vein, what must we do? These are easy. Say again, Brendan.
Restart another IV?
Yep, we got to restart it. It's got to come out. We're not going to piddle with it. If it's not in the vein, it's no good to us. So we're going to discontinue that IV. What are we looking at when we discontinue that IV? Do y'all not know, or y'all don't feel like talking to me? What are we looking at?
To check and see if it's still intact.
Yes, we are making sure that catheter tip is intact. If our patient is showing signs and symptoms of circulatory system overload, what do y'all think we're going to do?
Stop the infusion.
Yes, ma'am. We're going to stop the infusion and we're going to call our physician for further orders. We're not going to just let it keep rocking and rolling and they're short of breath and their pressure is shooting up and they're going south and just wait. We're going to stop that transfusion and we're going to call our physician immediately and see what he wants us to do. When we call our physician, what are we going to tell him?
You're going to tell them the current fluid overload?
Gonna tell him what? I'm sorry, Carly.
Tell them like why you discontinued it?
Yes. So you just need to, I want y'all to get in a habit of, so obviously you needed to call the physician, but they want the facts and they want them in a hurry. So knowing, say, hey, Mr. Baker, he had normal saline at 125 miles an hour. Wow, you can tell it's Monday, huh? He had normal saline at 125 milliliters an hour going. He's been fine for the last 2 days. It was infusing. I went in there about 5 minutes ago and he was short of breath. He had 2+ edema on his bilateral lower extremities, and I checked his pressure and it was up. His baseline's like 120/70s, and whenever whenever I went in there just now, his pressure was 158/95. I went ahead and stopped the stopped the fluids until I talked to you. He's really looking like he's got some fluid overload going on, but I just kind of wanted to touch base with you and see what's up. Okay? Don't just call him and say, hey, because you get nervous. Jot you down some stuff so you know to give him the facts, what you're telling him, so he has confidence in your assessment, and also you can give him what you need without piddling around, as opposed to a phone call that says, hey, I stopped Mr. Baker's his infusion of saline. Okay, why? Well, he was kind of short of breath. Okay, and he's got CHF. Of course, he was short of breath. You know what I'm saying? Making sure that you have that subjective and objective data to back it up, to support, your interventions. Let's see, and we'll talk a little bit more about infiltration. Y'all know what that is yet? Okay, so infiltration, obviously I know what it is, but I'm going to read you the exact definition so I don't mess y'all up. All right. I can't find it. I'll find it in a second. But infiltration is when the solution is leaked out of the vein into the surrounding tissues, okay? Okay, so the actual definition is solution is deposited in the tissue outside of the vein, which is basically what I said. I thought it would be a little bit more, a little bit more specific than that. So infiltration is the solution is on the outside of the vein. Phlebitis is when the vein itself is inflamed. Okay, so you could still, with phlebitis, the catheter could actually still be intact and inside of the vessel, but it's very irritated and it's inflamed. So it's causing pain and redness. Generally with phlebitis, that IV needs to come out as well. Sometimes a little cool towel can help it, but usually by the time that vein is irritated, it's better to just start a fresh IV somewhere else. Ecchymosis is just bruising. And then hematomas are just, it's like a bruise, but it's kind of like a raised, hardened bruise underneath the skin. A little bit more, where that blood has collected right there underneath the skin. Okay. So we want to treat the adverse reactions based on what they are. So if it is just a bruise and your IV solutions are infusing without problems, then we really are not concerned to stop that IV, right? Because they just bruised a little bit when we inserted it and it's still going in, and there's nothing that's putting the patient where they're unsafe to receive that medication. It might look a little bit ugly, but they are okay in regards to continuing to receive IV therapy. Infiltration, it's usually going to be seen by swelling at the site. So y'all know how when we start our IV and we flush with that 10 cc's initially, if it puffs up and makes a big puffy spot, that is infiltration. That fluid is going around, it's going outside of the vein into that surrounding tissue. So infiltration, there is no saving it because it's not in the vein. So we want to stop the fluids, take that IV site out, elevate the affected limb. Why are we elevating the limb, guys?
Help the blood go back.
Yeah, so we want that fluid to absorb back. We want to decrease that puffiness, and we want that fluid to go back into systemic circulation. And we're going to apply a warm compress. With phlebitis, you are going to see, excuse me, redness, pain, swelling, and warmth at the site. We're going to discontinue that. IV. And often a cool compress will help with just the discomfort associated with phlebitis. We want a warm compress for infiltration. And with phlebitis, usually once that catheter is out, that inflammation and that swelling and irritation is going to decrease on its own because we've removed the irritant. Does that make sense? Hematomas and ecchymosis, we said, are discoloration of the skin. Not a whole lot you can do for them. We want to calculate the flow rate correctly, and we want to continuously assess. So a peripheral IV provides access for fluids and medications directly into the circulatory system. I think this is all repeats, but we'll go through it anyway. We use them to replenish fluids and electrolytes, administer meds. They're usually located in the cephalic and basilic veins. So if y'all look in your book, I believe there is an example. It's in chapter 36 of the Green Book. And it's on page 717 if y'all locate that book. If not, I'll make a copy next time I'm at the school and give it to you guys. So those are the two most common veins, the cephalic and basilic veins. The biggest thing you need to understand about peripheral IVs is that they are for short term. Are y'all still seeing the same slide? All right, so I want to change slides. Okay. Central lines are access that are used for longer periods of time for medication administration. If your patient has osteomyelitis or they have an infection that requires treatment for a long period of time, then we're going to put in these larger veins. Central lines are placed in the jugular vein, the subclavian veins, and the femoral veins. You do need to know the difference of, where we would put these types of lines. They're used for loss of IV access. So if we just cannot maintain a peripheral line, or if your patient just has absolutely no problems. So these larger veins, so peripheral veins are preferred, but if your patient just absolutely positively has been stuck by yourself, multiple nurses on your units, the anesthesiologist, and no one can obtain access, then we would put in a central line. If the medications that you're administering peripherally are repeatedly causing phlebitis, if they are just tearing up your patient's veins and you cannot maintain that line and you're changing sites continuously, your patient may be a candidate for a central line. And if your patient needs medications for longer periods of time, which we already talked about. All right. So in regards to documentation, in regards to administering these medications, we want to make sure that it's the same as your medication administration. You want to make sure that it's the right solution. the right dose, route, time, patient, and documentation. So it's really the same thing because you need to think of it is a medication, you don't need to think of it like that, but your IV solution is your medication. So if your order is for half normal saline is not the right medication. You just need to ensure that it matches your orders exactly because they're not interchangeable. And then we've already talked about the indications. Okay. What questions do you guys have about just kind of that intro to IV therapy? None of it probably sounded too foreign.